Hi, thank you for joining us today for this important conversation around COVID-19 and the impact it has on the MDA community. I'm Kristen Stevenson, MDA's Chief Advocacy and Care Services Officer, and I'm honored to be joined today by Dr. Barry Byrne, MDA's Chief Medical Advisor and who serves as Associate Chair of Pediatrics and Director of the University of Florida Powell Gene Therapy Center.
Thanks very much, Kristen. I'm glad to be here.
Thank you. And please remember that we're thrilled to have Dr. Barry Byrne here today as a medical expert, but understand that Dr. Byrne is not providing medical advice today. Any decisions about your care should always be made in conjunction with your doctor. We know that this is a time of great uncertainty, and we at MDA are here for you. We also know that people living with neuromuscular disease, including muscular dystrophy, ALS, and related disorders, have important questions related to COVID-19. We'll spend the next half hour answering your questions about COVID-19 and its impact on the neuromuscular community. And thank you to everyone who submitted questions in advance, and we'll do our best to address as many of them as possible during the time we have together today. And before we jump into the first question, Dr. Byrne, would you mind sharing your spray bottle tip that we were just talking about before we jumped on?
Sure. Yeah, everyone's worried about transmission on solid surfaces, so I thought this worked out pretty well. If you have any eyeglass cleaner, you can take that little bottle and use it to spray any surfaces you think are contaminated, and that's really important in the home, or particularly if you're anywhere outside the home. So just remember, use little rubbing alcohol, and that is really good for irregular surfaces that may not be appropriate for hand sanitizer.
It's a great trick. It's a great trick, and I wish I had known about the spray bottle several weeks ago, but I'm definitely going to be getting one for myself soon. So Dr. Byrne, without further ado, let's get started with our first question. So the first question is, can you give an overview of what COVID-19 actually is and why the neuromuscular community is at an elevated risk?
Yeah, COVID-19 refers to the disease caused by a family of coronaviruses, the beta coronavirus family, and this particular one that causes severe acute respiratory syndrome, or SARS. SARS coronavirus 2 is this recent version identified in December of last year in Wuhan, China. And it's been particularly virulent because it's known now that a subset of patients who can transmit the illness without having any symptoms probably has accelerated the success of this virus in propagating really throughout the world and causing the current pandemic.
Thank you for that. And the next question is about the symptoms of COVID-19. And the question reads, what are the symptoms of COVID-19 for the neuromuscular community? Are they the same or different than symptoms for people who are not living with a neuromuscular disease?
Sure. Yeah, we expect that the symptoms are quite similar. There really is an important distinction, though. The susceptibility of patients on glucocorticoids, prednisone, or similar drugs is heightened. And it's important to keep in mind that about 90% of patients will have fever. Some people dependent on their glucocorticoid dose may have an attenuated fever, and that is important to be able to then measure objectively with the proper thermometer, not just relying on whether somebody's warm or not, because it may not be the high fever that's observed in others, but it also means that there's a greater likelihood the virus will not be as impacted by the host immune system and cause a more rapid and severe illness. So fever, aches and pains, the chills that come with fever are common symptoms, as well as cough and difficulty breathing. So obviously this disproportionately impacts people with neuromuscular disease who have weakness and have respiratory difficulty because of that weakness. So that's why it's important that they seek medical attention very quickly if they have any concerns, whether they themselves are infected or they expect that they were exposed through direct contact with a family member.
Thank you. And the next question is about telemedicine visits and having telemedicine visits in the MDA Care Center. So before I turn it over to you, Dr. Byrne, to answer the question, just as a quick note to those who may be joining us today who are not familiar with what an MDA Care Center is, the Muscular Dystrophy Association supports a network of multidisciplinary clinics across the country in more than 150 of the country's leading healthcare institutions. And those clinics all together are what we refer to as the MDA Care Center Network. And so if you're not familiar with the terminology in this next question, just wanted to give you a little bit of detail around that. And if you are interested in learning more about the MDA Care Center Network, please visit mda.org. And we have a landing page there along with a finder, and you can look for a site that's closest to you. So the question, Dr. Byrne, is my care center wants me to have a telemedicine visit, but I would rather wait and go in person. What should I do?
Well, obviously, it's important to just stay in contact with your care center providers because right now, elective visits are really suspended because we're trying to keep people in the home or around their homes and out and staying out of the public. So right now, the best thing to do is to connect through this telemedicine mechanism. Really, the best practices have been shared among the 150 care centers across the country. There's a lot of innovation that's gone into making those easy for patients, and certainly those with mobility challenges are hopefully will find this a new mechanism to stay in close contact with their care center providers. So start there with the telemedicine visit. There'll be an opportunity to meet again in person soon.
That's a great segue into the next question, which is really about kind of the uncertainty around things and when they will return to what we kind of considered normal up until a month or so ago. The question reads, I'm concerned that my care center visit has been canceled and I'm not sure when I will be able to go to another one. What should I do?
Well, the care center team will reschedule as needed for visits that are anticipated coming into the future. And right now, those may be telemedicine visits. So even though the in-person visit was canceled, there'll be an opportunity to reschedule that telemedicine visit, have that initial interaction for both health maintenance and any concerns that patients have about illness or medication refills or any of their needs. And let's focus on getting those first visits done to adjust to this new means of communicating. And then and I hope that by the summer, there'll be an opportunity for in-person visits to resume across the country.
Another question about clinical trial involvement. So this question reads, I'm currently participating in a clinical trial. How will that be impacted by COVID-19? And we know this is something on the minds of a lot of individuals who are either in a clinical trial or are wanting to join a clinical trial. What are your thoughts on that, Dr. Byrne?
Yeah, the federal government has put out guidelines for management of clinical trial visits, and they're in tiers. So the first tier of clinical trial research relates to COVID-19 disease itself, and then the subsequent tiers relate to whether there's direct benefit to patients or any potential for exposure to either other infected patients or healthcare providers. And those are paused now so that we kind of keep patients safe, out of harm's way, at places where patients who are sick with the disease are coming. So if we focus at least on those visits where there's potential for benefit to the patients, those will continue. And that includes many forms of ongoing clinical research where there are therapeutic options for patients. And then there's forgiveness of missed visits, and some of those will be done by telemedicine when possible.
Great, thank you. The next question is, how is MDA supporting families through this time? So I'll go ahead and take this one, Dr. Byrne. I would encourage you to stay in touch with MDA through the MDA National Resource Center. We have a team of individuals, specialists, and coordinators whose full-time job is to be available to you to answer questions, to provide you with information, to direct you to resources that may be helpful in your community as well as at the national level. We're available during normal business hours 5 days a week by phone and by email, and we're here to help. And if there's anything that you need and we're not able to help you directly, hopefully we can point you to a resource that we're aware of that might be able to be another avenue for you. I would also say that if you are interested in being seen in an MDA care center and are not currently being treated by a clinician in the care center network, please do take a moment to look at the care center landing page on MDA.org, and you can get some additional information about the clinic locations as well as contact information for making appointments at that location. We're also very quickly pivoting our community and education programming from being primarily in person to being virtual. I think that this is really an exciting opportunity in a lot of ways for us to be able to reach many more individuals through this virtual programming than we would have been able to reach through the in-person. And while of course there's always an advantage to being able to be together and to connect in person, this may open up a chance for a lot more people to participate who maybe wouldn't have been able to travel to an event, or who may not be able to navigate a certain type of space outside of their home. So we are hoping that this will actually increase the number of individuals we're able to engage and include in all of these virtual events. I think also being an MDA advocate is incredibly important at this time. We have a dedicated public policy and advocacy group in Washington, D.C. that is staying on top of all of the COVID-related legislative efforts, as well as driving our regular priorities through. And if you are not currently an MDA advocate, I would encourage you to sign up. All you need to do is go to the MDA.org advocacy landing page and share your email address, and you will get action alerts and advocacy emails coming directly to your inbox. So thank you for asking the question. And of course, programs like the one we're doing today are other ways in which we're trying to support the community. So thank you for joining us here. Dr. Byrne, the next question is about medication shortages or concerns around potential medication shortages. And the question reads, I've heard there are shortages of medications that our community relies on. Are you aware of any of these shortages for the community?
No, I think the conventional medications that are used chronically in the neuromuscular patient population are probably sufficiently distinct that they're not going to be an aspect of the care of patients who are presenting with any coronavirus-related disease. So hopefully there won't be any impact on this patient community by the increased utilization of the healthcare system.
That's consistent with what we're hearing as well. We know that we do get a lot of outreach to MDA on this question. Obviously, it's ever present on people's minds, and rightfully so. Just from a policy and advocacy standpoint, I'd also share that while we as an organization are unaware of any current shortages that are approved by FDA for use in neuromuscular disease, we do routinely check the FDA drug shortages portal, and we're monitoring those lists of all ongoing shortages. We're also keeping in close contact with both the FDA directly as well as manufacturers of therapies that are critical to treating individuals living with neuromuscular disease. We're going to continue tracking the medication supply, and should we see anything of concern, we'll certainly share that out with the community as well. The next question, Dr. Byrne, really has to do with triaging and choosing who gets what kind of treatment and when. The question reads, I heard of a woman who was told that she would not get access to a ventilator if she gets COVID-19 because she has neuromuscular disease. What is being done about this? And I'm certainly happy to talk about that from a public policy standpoint as well. But Dr. Byrne, let me turn that over to you from a clinician's perspective.
Yeah, the same rules are going to apply to all patients who come in need of respiratory support. One thing that's worth mentioning, though, is that hospital systems utilize a closed circuit in which the breathing apparatus doesn't vent into the environment, so where the healthcare workers are exposed. So people using both non-invasive ventilatory support or even the conventional home ventilator, like a Triaging machine with even a tracheostomy, would not be able to use those devices in the hospital, unfortunately. So we hope the best management of that is to keep our patient community out of the hospital. But there should be no reason why they wouldn't have access to the care that any other patient would have.
Thank you for that, Dr. Byrne. And I would add that just from a policy and advocacy standpoint, MDA is also working with multiple stakeholders across the patient and the disability advocacy space on this issue, which really gets to the heart of kind of the concepts of care rationing and triage. And last week, the Office of Civil Rights and the U.S. Department of Health and Human Services offered guidance to states emphasizing the need for patients with ongoing health conditions like neuromuscular disease to be treated without discrimination. We were very pleased to see that guidance issued, and there's still more work, however, to be done to ensure that states and hospital systems are treating patients living with neuromuscular disease based on their health care needs related to COVID-19, not on any discriminatory or practices or perceptions about treating people. And we're also going to continue working on this going forward. And again, if it's something you're interested in, please do join us as an advocate, and you will receive updates on these types of issues as well. The next question is another policy question. The question reads, how are the emergency bills in Congress helping the neuromuscular disease community? And Dr. Byrne, I'm happy to tackle this one or turn this one over to you first and then comments. Okay. So there are several emergency bills that have passed Congress recently, and they've all had important impacts for our community. I would say that the piece of legislation that probably helps the neuromuscular community the first, at least to date, is the Families First Coronavirus Response Act. That bill does a few things, but perhaps most relevant for those of us here today are it offers no cost, coronavirus testing to be made available to everyone. Increased support for Medicaid programs across the country are also included in the bill's provisions. Measures that enable people to practice social distancing are addressed, and low cost or no cost sharing in Medicare, Medicaid, and other programs for treatment are all aspects of this law. Also, among the economic measures that were included in the large stimulus bill passed last Friday were increased funding for health systems, including hospitals, which would, of course, also help the neuromuscular community during the pandemic. And finally, there will be, or at least we anticipate there will be more legislation in the near future that will be critical to our community. And if you're interested in staying up to date on the current and to follow legislative activities around COVID-19, again, I can't say it enough. Please do become an advocate, and you will get that information and the opportunity to take action and to reach out to your lawmakers directly through your inbox. The next question, Dr. Byrne, is about the changing and sometimes anyway, seemingly conflicting advice on who should wear masks and when people should wear masks. So the question reads, at first the U.S. Surgeon General and WHO told us not to wear masks unless we had symptoms. Now I'm reading about needing to wear a mask. Should we be wearing a mask? Should I ask my home infusion nurse to wear one?
Well, that's a very good question because we are seeing changes in recommendations partly due to gaining additional information as this process now is really in its full-blown stage in the U.S. And so some of the initial recommendations were, how does one stay protected from infection? And there's a certain type of mask which allows one to, particularly healthcare workers, to avoid an infection from someone else. The purpose of the current recommendation is a larger proportion of the population is exposed, and there's the potential for this asymptomatic phase where their transmission can occur. The mask helps lower the rate of transmission of the person wearing the mask to someone else, not protecting them. So that is principally to avoid this spread, aerosolization through spreading, and that causes spreading on solid surfaces. So if someone is wearing a mask, they're going to be a little more conscious about that. Coughing and sneezing is not going to have as big an impact. So that's what's led to this current recommendation that I think we'll see in the next day or so, a pretty uniform recommendation to wear masks. The other aspect initially was a recommendation against this so that some of the protective personal equipment was available for healthcare workers where they knew there was going to be an exposure. We certainly hope there's an increased supply of these materials for everyone that has to be out in public. Certainly, if you're in your home, this is not necessary. If you're around your home, but just outside, but not in a public space, this is not critical, unless there's uncertainty about others in the home who do have the need to go out to public places, and that's another reason to wear, for example, your home infusion nurse has to go about their regular life when they're not working, and you have to be certain they've not been exposed when they're at work or out and about. So yes, it would be very appropriate to have any healthcare workers in the home to wear masks when they're around a patient who has this susceptibility.
Thank you. Yeah, I have to say, I've also found myself trying to sort out the mask advice from time to time, but I think it's a really interesting insight to think about the mask not only being used to prevent being infected, but also to prevent spreading any potential infection.
Exactly.
The next question is from a parent of a child living with neuromuscular disease. And the question reads, could you please give us parents steps we should follow if our child gets sick right now or within the next few months during this pandemic? Who should be our first point of contact?
Yeah, obviously, not everyone lives in close proximity to a care center, so I think it's important to rely on your community providers, whether that's the pediatrician or a subspecialist that's practicing independently. If that's the best way to get kind of eyes on the situation right away. If the child is ill, of course, call first, get instructions on how and when to be seen. And then those providers can be in touch with the specialists at the MDA Care Center, either by phone or we're making ourselves available through telemedicine for other providers as well to provide advice and guidance. And then, some of those care center providers are in tertiary, quaternary medical centers where someone's really sick, they could be transported. But we hope that for now, these isolation procedures will keep the patients in the neuromuscular community safe.
Thank you. The next question is about the heightened risk for the neuromuscular disease community and really trying to understand, is it everyone in the community or is it some cohort of the community? So the question reads, are all individuals living with neuromuscular disease at elevated risks for COVID-19 as we are hearing about for the elderly community?
It probably is true, Kristen. That's a good point. Because of both the respiratory difficulty, impaired airway clearance, and coughing ability is a feature of for many patients with neuromuscular disease. So that's going to make them more susceptible to pneumonia-like illness. And the other risk factor is the use of medications which impact immune response, like glucocorticoids, used commonly in Duchenne muscular dystrophy. So we do have to have a really heightened awareness about this problem for the neuromuscular community because of those two circumstances.
Thank you. This is an interesting question. This is about your personal experience in treating individuals diagnosed with COVID-19. So it says, Dr. Byrne, have you or any other doctors in the Care Center network treated anyone diagnosed with COVID-19?
Right now at our center, really focusing on the northern half of Florida, the almost 10 million people in this area, we've been lucky to keep those patients out of the hospital, try to address any needs they have through the telemedicine portal. There's almost certainly going to be some exposures and hopefully no hospitalizations, but it does impact the community in another way because there are other needs that patients have that often rely on coming to the hospital or to the outpatient area, and all of those elective visits are on hold now. That may mean even for hospitalized patients that they would need to transition to home more expeditiously because we're trying to make sure they're not in the same environment as patients who are being admitted for this condition. So yes, there's been an impact. There's going to be an impact on the availability of providers' time and the complexity of the care of patients after this acute phase of the illness. And you see the number that are listed as resolved is far less than the number that are where there's been documented infections, partly because there's a very long delay for those that have been exposed in terms of chronic lung conditions that might worsen the situation for people with neuromuscular disease. So we really want to practice the most strict isolation as we can.
Mm-hmm. Thank you. The next question is about BiPAP. And the question reads, I use my BiPAP machine 24/7. Is the filter satisfactory to shield me from the virus like a face mask? And will the BiPAP work as well as a hospital ventilator? So really kind of two questions in one. I guess the first question being, will the filter in the BiPAP act like a face mask for shielding purposes? And then the second question is, will the BiPAP work as well as a ventilator in a hospital?
So the filter in a BiPAP machine is designed to prevent particulates that come out of breathing, but not viruses. So it's actually not protective of an infection. And plus, those devices actually vent during the inhalation, exhalation. They vent right at the face mask. So those filters that are those devices that are not a closed loop circuit, like in a hospital ventilator, are not protective. And but they're obviously necessary for people to maintain their ventilatory function, particularly at night when breathing volumes diminish. But they don't substitute for what's needed in case of a pneumonia, where higher volumes, more pressure is needed to be delivered to the airway. So keep using the BiPAP. Don't change the medical regimen. But if there's any illness, call right away.
Thank you. And this next question is, I think a lot of us are right now trying to sort out what we're hearing in terms of, fact or fiction. And so this next one is along those same lines. And it says, I've heard the cough assist device can be converted into a ventilator. Is that true?
Yeah, unfortunately, that's not true. The cough assist device uses very small volumes of air to, in effect, vibrate into the airway and free up mucus. It does not provide enough volume in and out of the lungs to provide adequate ventilation. So no, it can't be used in that way, but it certainly is important for pulmonary hygiene to keep up the use of the cough assist, because if there is a mild infection that causes increased airway secretions, we're going to want to stay ahead of that. So the cough assist device is a really important part of the overall care, just not in place of the devices that we need to maintain adequate ventilation.
Thank you for clearing that up. I can see that if that was a misperception, that's one that that could be quite serious to not understand the reality there. The next question is about pivoting to home infusions as opposed to inpatient infusions. And the question reads, my husband uses invasive ventilation at night. He has been having bi-monthly infusions at the hospital for 15 years. How safe is it for him to continue going to the hospital for his infusions? If taking his infusions at home becomes an option, would home infusions be a safer option?
Yeah, this is an ideal time to try to convert to home infusions, because the more you can do to limit exposures and stay out of the hospital setting, the better. And in fact, what are considered elective procedures now are being discontinued in the hospital setting. So it's better to plan ahead, work with the home infusion company, and get the infusion set up to be done at home.
Thank you. And here's a question really having to do with prevention. Besides self-isolation, hand washing, and disinfecting, do you have any other suggestions of what we should do to prevent being infected with the virus? And I think you started out the conversation by sharing the spray bottle trick, which certainly fits into there. But are there any other tips or tricks or suggestions that you would have to share?
Well, obviously, once you're inside the home, hopefully, if all the surfaces are cleaned and you have very little traffic in and out of the home, that's really your safe zone. Obviously, my own practice is if I go in and out of the car, I'm hand washing when going into the car. So the car is kind of like home. I know that it's safe. Then at home, I wash my hands again when I get in the house. Soap and water works quite well. I don't have to use hand-based hand sanitizers or alcohol-based the materials, but stick with soap and water. And then it's important to consider that sometimes we're not certain of where materials, groceries are coming from.
Mhm.
So it's a good practice just to use a a paper towel or a home wipe, something that you can dispose of and wipe those surfaces down, or use this little spray bottle again.
Thank you for that. This is our last question that we'll have time for today, but I think it's an important one and a good note to land on. The question is, why does the virus affect people differently, and are there any treatments for it currently?
That's a great question. It's kind of ironic that usually we are immunized against infections of various kinds by getting exposures during childhood and then later life on an immunization schedule. And that usually lessens the severity of illnesses. That's why we recommend everyone has access to the flu vaccine. It may be that the most severe illness in patients in this circumstance are the ones that have had no exposure to the very often observed related coronaviruses that cause a common cold. So the reason that's suspected now is because some patients, even younger ones without age-related comorbidities, are being identified as having a severe form of the disease. And this may be because of an overexuberant immune response that's causing damage, particularly in the heart and lungs. So there's increasing evidence that there is some, in those cases that would be considered severe or critical, that there's involvement of the immune system. Then there's evidence for that in the SARS-1 outbreak, and then they're building evidence for that in this current environment with SARS-2. So that's something that will help teach us about ways to provide treatment. Certainly, patients that have had high titer antibody after experiencing an infection can be potential donors of that antibody. That antibody's been decoded, if you will, by some companies who are trying to make renewable monoclonal versions of those antibodies for use in treatment and prevention. And of course, the most important form of prevention will be vaccines. The challenging part will be to get vaccines in place this season. Right now, this virus has not changed much since December because it's been so successful at spreading around the world. But there is the possibility that this will transfer to the southern hemisphere for their winter and then come back again next season. That's not meant to be overly concerning, other than that we have to continue this really amazing collaboration that's happened among scientists around the world to share information and strategies for developing vaccines. There are now over 50 different types of vaccines under consideration, some already in the clinic, and so we hope that those are successful as soon as possible.
Indeed. And one of the things you and I were talking about earlier that I also found, I think the word hopeful is exactly right here, is that it sounds like when there is a vaccine available, healthcare workers obviously on the front lines would be prioritized in terms of receiving a vaccination. But it sounds like particularly vulnerable populations, including populations like the neuromuscular disease community, might also be prioritized in terms of having access. And
yeah, absolutely.
I think that's a very hopeful thought for all of us to be able to leave our conversation with today. So, Dr. Byrne, thank you for everything you do every day, and thank you for spending your time with us here this afternoon. We really appreciate it.
Glad to be here. Thanks. Everyone
Thank
stay
you.
safe.
Yes, and thank you for joining us today. We really appreciate it. If you were unable to join the full conversation, the recording will be available for playback on Facebook, as well as mda.org/COVID-19. Which is the same I just shared, which is mda.org/COVID-19, as well as this Facebook page. Thank you again for joining us today. We hope that you and your loved ones and your friends and families stay safe and well during this challenging time. And please don't ever hesitate to reach out to MDA. We're here for you and we're here to help. Thank you.